He had anterior myocardial infarction on 14th of November, and the angiography, he was thrombolized, subsequently stabilized. Angiography was done day after, which had shown some significant left main stenosis along with mid-LED stenosis. So he was planned for left main plus ostial left main plus mid-LED angioplasty. So now I am showing you today's angiograms. Show. First. Next. So seeing that there is some ostial stenosis, we decided for IVUS, and I will show you the IVUS pictures. So the IVUS interpretation, Dr. Hamazaki will tell.
Yeah. As you can see, from the IVUS findings, ostium of LMT, it looks not severe.
Not working.
So, in my personal opinion, it is not necessary to perform PCI for ostial LMT. How do you think about that point?
So we need a panel's opinion. Here after putting the guiding inside, we get a ventriculization of the pressure. The patient had significant dia hold up after putting the guiding, and there is a plaque at the left main ostium which is best seen minus, sin plus. You can see this. This is the plaque at the left main ostium, aorto-ostial junction. So what is the opinion of the house?
Okay, please can you tell us anything about the history of the patient?
Patient had anterior infarction on 14th of November. LED territory.
So one more concern here, the IVUS measurement, I thought they did not show very critical stenosis as you see in the angiogram, unless I am not seeing the correct frame. There is also a LED stenosis. And what is the viability status of myocardium if he had an infarct?
We had not done viability studies in this patient.
So, I mean, you understand if somebody infarct, LED infarct or left main infarct, and if it is completely non-viable, you are taking a procedure with risk but less benefit.
Yes.
And I would like to see a clear IVUS picture because left main ventriculization angiography, they are relic of a bygone era. If you are stenting a left main, you have to have a critical stenosis.
Yes. So I will show you another run-up for IVUS.
Yeah, this seems.
This is the now left main plaque starts. And this is the maximum stenosis at ostium.
And there is a LED disease also.
Yes, there is LED disease. Ejection fraction is around 45%.
Okay, that's not bad. I think then you probably don't need viability in this case.
Yes?
please, without the measurement just now, the IVUS, can you put that on the main screen? And just no need for dual. Put it on one
Without
big screen.
measurement, you put this.
And
One second. I'll put it one. Without
without the measurements, actually,
you have to
so
put it on,
you're getting at
put on main screen, without measurement.
6.1. So, I mean, I think it's 6.1 right now. So let's take a panel vote. The LED is significant. We are not questioning about LED is going to be done. I want the panel to vote on how many of you would go and intervene on a left main ostium, which is 6.1. Yeah, nobody? I mean, panel, you have to vote yes or no. Coming from the other end, Dr. Pin, left main IVUS area 6.1, would you intervene on that?
I think that is a patient for intervention, definitely yes, but for me is we need to have also discussion with the vascular surgeon. All left main is a guidelines to have a heart team before intervention. And also from my point of view, I need some point of surgical view in such a case like this. So we need
but
also
from European guidelines, left main with syntax score of 22, which falls into this patient, PCI is a level of class 1, level of evidence B, same as bypass surgery. So yes, you have to obtain heart team approach in the United States, probably yes. But anyway, right now I'm asking the question about IVUS. Next.
I think the culprit lesion is clearly LAD. It means I would stent LAD, and I think it's quite easy to be performed the procedure of the left main. It means I would do also the left main.
Okay, with an area of 6.1, you're okay. Yeah. Next, Dr. Ortega, 6.1.
Use a FFR in this case.
Use FFR. Okay, that's but we don't have FFR. We only have IVUS. Would you go ahead and stent it? Yes. Okay. Yes. Okay. Deepak.
The clinical
I think we need more information here because 6 millimeter and more free lumen create a conundrum for left main.
Madam.
However, if this lesion caused an infarct recently, we should treat it. FFR, I will beg to differ, is not very accurate for left main. In a big left main, FFR utility is very limited. So, other thing is they are using Boston, probably rotational IVUS. The images have artifact. And I'm not used to these images. We need more clarity. Maybe a virtual histology. If the plaque is soft, I will treat it.
So the answer for boards is, in case if a patient is symptomatic and has an IVUS left main area less than 7, you fix it. If it's asymptomatic, IVUS left main area less than 6, you fix it. So this is 6.1, which is less than 7 in a patient with a recent MI, and we are considering the culprit is LAD. There is no doubt. So that is why the gray zone, this falls under a gray zone, because we cannot say with sure that it is a left main which is symptomatic here. So Dr. Mahajan, please go ahead and show us what you have done next. Yeah. One comment from the panel.
No, yet I had not done anything. I had not done anything. Just waiting to hear from the panel about the left main and LED.
80% say to go ahead and stent it, but we have one more question from the panel.
You know, if you have then 6. Here we have 6.1, and you will make a procedure on LAD. It means you will manipulate with the guiding catheter on the left main. It means you can endanger the left main. It means for me, it's if it is 6.1 and I have to work on LAD, I should also do the left main.
from my point of view, geographically the left main looks very diseased, so it's difficult to leave the patient alone after when you have the patient on the table. So this is not complex PCI with this osteum of LAD. So I also support Dr. from Czechoslovakia that I will do also the left main.
Okay, Dr. Christoph.
I just wanted to say exactly the same. My friend from Poland, because he looks severely diseased. As you see, it is you're giving the contrast into the aorta. You can see that the lumen is like less than the size of the catheter. So, if I may suggest, can we go through the IVUS frame by frame and evaluate if this is really 6.1? I have some doubts. I really apologize for this
I
comment.
think it's below 6 actually. But anyway, we agree, even if you say it is 6.1, I think the drawing is a little bit more inclusive of intima as well. So I think you can go ahead and proceed with the case in view of time.
I agree.
So now my question is, should I go for mid LED first and then left main, or should I go left main first and mid LED?
No, mid
If you
LED
take
first.
my opinion, I will go for mid LED first and then left main.
Yes.
Yeah.
Yes. I mean, traditional teaching is
So I'll go
always
for
distal
mid-LED
first. Yeah.
Yes. So give me 2.75 in 13
What about IVUSing that
for
LED?
distal.
I mean,
I had not done it. So I had not put the IVUS catheter distal to the stenosis.
you should have. I mean, it's you already paid for it.
Balloon stent direct. So give me PA cranial. So this is the LED lesion. So our plan is put a stent, primary stenting, because it is a thrombus containing. We can put a 3 mm stent. 3 कौन सा size? Give me 3 mm. थर्टीन पेक्षा लॉन्ग कौन सा है? 13 पेक्षा लॉन्ग कौन सा है? Give 16.
Excuse me, could you please note that
Yes.
the backflow of the contrast from the left main? It's very low, backflow. The backflow from the left main during contrast injection is very low. It's also an indirect sign that the stenosis seems to be very critical.
Yeah, certainly. But if your injection is wimpy, then you won't get.
See, I had used a side hole catheter. This is side hole guiding catheter.
So it will give you a false confidence in landing the stent.
Yes.
So this is for the audience. Side holes are to be used sparingly because they will give you a false confidence. You will miss the osteal stenosis if you use side hole catheter.
तीन आठचा बलून पाहिजे. We are putting a 315.
My question is, what about the diagonal branch? It's arising from LAD. It's not small artery. What do you mean? You do not need to protect them during the stenting? What do you mean about that?
See, while doing a left main and I don't want to make it a more complicated procedure. And since the diagonal ostium is not having any disease, I had not put any wire in the diagonal.
What size of the balloon do you use? Which balloon and what inflation pressure?
This is a 3 by 8. 3 by 8 at 14 atmosphere.
3 millimeters, 8 millimeters long, and 14 atmospheres. And the stand was which
Yes.
size?
3 by 16.
Yeah, it means it is not classical pot dilatation because you use the same size of the balloon as for the stand. Is it correct?
Yes. Yes. Now we'll plan the left main. Come, RO caudal. So what size should we plan? 3.5 or 4?
I think you should be
IVOS diameter is 3.8.
No, you should be guided by your IVOS measurement for the diameter and the landing zone. Like your LED stand has
Yes.
landed in a 50% disease zone, which is not a good way to land. So I think if you haven't taken a measurement, put back your IVOS catheter and get repeat measurement.
Okay. I had already taken the measurement, it is 3.8 millimeter. So we'll repeat one IVOS.
Yeah, and save frames where and take a angiogram where you want to land your stent so that you know what is the length of the lesion.
Yes. Yes. So putting the IVOS.
And this is for the audience. I
PA
strongly
cranial.
recommend
PA
a volcano marker IVOS. You know, it has 10 millimeter marker, 3 millimeter tip. You can get precise landing zone.
So we'll do the IVOS from distal to the proximal. No, start. Okay. LED. First LED, stented segment.
The lesion distal to the stent is significant, isn't it? LED.
चल RO caudal दे. Hold. We'll do the left main now. Now this will be the IVOS of left main only. Now you start second run. Okay, hold. So give us the size of the left main. Flush करो. So the shortest length available is 13 millimeter. So we are having 3.5 13 and 4 by 13. 8 is also available. 8 is also available. Okay. Kiti, what is the diameter? Huh? 3.8. Take elevocranial. You doubles. So we'll plan for 4 by 8.
What does the audience think? 4 by 8. I think they are silent, so go ahead.
The 4 by 8. What is the pressure? So it is a 4 by 8 biomime.
How much pressure you went up to?
12. IVAS. We'll do the IVAS now.
I would. I mean, what if you have to flare the ostium?
It's already flared, but
Well, you are trusting your eyes.
you can show. Yeah, 1 second. I'll show you. Sin minus. You can see this picture now.
Yeah, but what's the wrong with?
So
if
there
you
is some
already-
flaring at os.
Okay, that's, I mean, angiographic is okay, but by convention, I'll tell you, this is for the audience. Left main stent is the easiest
Yes.
stent to do. Ostial left main is
Yes.
the easiest artery to stent. So,
Yes.
so I think, but it's an important artery. You are obligated to confirm that you did a good job.
Yes, we'll do the IVAS and then we'll decide.
You know, one more reason for IVUS is you have a side hole guide, which will not damp pressure or tell you what's happening in the ostium. And the other reason is you use a 4 millimeter stent deployed at 12. So your vessel was 3.9 in the distal left main. So you want to see the
Yes.
distal edge.
Yes. So we'll start. Okay, show that picture. So. Show arrow caudal. Show epicaudal.
So what about circ? Who in the audience thinks circ should be investigated? Any thought?
What is the area?
Now we have in the area of 11.9.
11.9. Okay, show me spider. So now you have to tell me what to do. What is the opinion of house?
Can you check with IVUS how far to the aorta does the stent go?
Okay, okay.
Because from here it looks that it prolapses to aorta quite significantly.
Yeah.
Flush. Around 3 millimeter is in the aorta. We'll check with IVUS. Okay, start. Start pull back.
Can we see the IVUS image? Can we have it on a screen, please?
Yes. Yes. Can you show that pull back?
Yeah.
Actually, I think that when stenting just ostial left main or ostial right coronary, one good trick is that you put another wire besides the stent balloon, and the other wire goes to the aorta, and you can push the guide so that it does not go inside the ostium, but not so to prevent the stent protruding to the aorta also. So I would suggest that.
Yeah, I
that
agree
use.
with the audience, but I think the stent result is appropriate. Let me have a second.
Yes, I believe that in left main ostium, in this case with a lot of calcium, with fibrotic plaque, I believe that predilation and preparation of the plaque is mandatory. The watermelon effect that we all see during stent implantation wasn't necessary. And in the IBUS we see maybe 1/4 part of the stent in the aorta that was not a problem of the delivery, was during the inflation and the watermelon seed effect. So I believe that, again, predilation is mandatory in that kind of angioplasties.
So I don't disagree, but I'll take a little contrarian approach from these operators. First is, I'm not a believer in a side hole guide because it will give you a false sense of security and improper positioning. The lesion is not so tight. An experienced operator can push the workhorse wire and back out the guide. Second thing, it's not a crime to leave stent hanging 3 millimeter into the aorta. Nothing is going to happen. The problem happens if they have to go back in within next few days. The guide will not engage. And the second is, in this case they oppose the stent. If the stent is not opposed, you will not realize your wire will track under the stent and go into the sub. So I think that could have been prevented by using a non-side hole guide and a good IVUS markings. So, but I think the end result is acceptable.
So I think this stent result is very good. It is probably hanging into the aorta by 1 or 2 stent struts that is acceptable. And there are other ways that actually, as Dr. Carey mentioned, you can put a wire into the aorta, or even a Szabo technique where you actually make the stent strut, flare it, put a wire through that. People have done it in such a way so the distal stent strut, you flare it on the bench and put a wire through it and advance both of them together, so that it's called Szabo technique, that you can do it. Or Osteal Pro is a kind of a guideliner sort of thing, which actually will go and be exactly in the ostium, and you get enough coverage with the stent. So Osteal Pro is actually the indicated for these sort of lesions. But I think this is an excellent, I agree with Dr. Kapoor, that majority of us can do this without any problem, hanging down into the aorta a little bit, maybe 1 to 2 stent struts. Well apposition is very important here, well apposition, And still, sometimes you might get a problem getting a good guide catheter support later, but we can easily get away. Anything else? Before we move on to the next lecture? We have a couple more minutes.
So should I take out wire now?
I think so. We are happy with the result, and meanwhile one of the panelists has to say something. Doctor?
It means no post-dilatation?
No post-dilatation. Ileocranial.
I just want one more comments for the future. If the patient has some kind of chest pain, it's maybe better to perform angio-CT than angiography, because we should remember that the little stent is hanging aorta and we can damage during diagnostic angiography. So could be the option for evaluation instant restenosis left main CT
yes, for
angiography.
follow we'll do the CT end. Yes.
And what site of anticoagulation and antiplatelets would you recommend for this, Dr. Mahajan?
This is, the patient is already on ticagrelor with ecosprin, aspirin. 75 milligram of aspirin and 90 milligram of ticagrelor.
And normally, how long would you continue them in India?
We are just following the Western guidelines for 30 weeks
30 months?
and then we shift to single antiplatelet. 30 months and then we shift to single antiplatelet.
I have
He is on beta blocker, AC inhibitor, dual antiplatelet, statins and one folic acid.
I have one more question.
And most of the time we do follow up of these patients on echo guided, because echo we can see the left main ostium very well in short axis. So the now subsequent follow up will be echo guided, and if the patient is symptomatic, then we will do the CT coronary angiography or angiography, catheter angiography.
Thank you. Dr. Ota?
Thank you.
I saw one lesion on obtuse marginal. Can you have a look at it again? And what are your plans with this for the future?
Yes.
So the obtuse marginal disease, do you want to fix it now or fix it later? Later.
No. We are just offering medical management only because the vessel size is less than 2 millimeter.
Right.
Sin minus, sin minus, sin minus, sin minus, sin minus. This obtuse marginal, the vessel size is small.
I think it is big actually, because looking at the OM, distal OM size and also AV groove circumflex size, the ostial or proximal left circumflex must be bigger than 3 millimeters. But I don't think that you need to address it right now. I would say that in the future you have to either do a stress test and see if there is ischemia in that, and stage your procedure, because this is a recent anterior wall infarction, and I think you're right going ahead with the left main and LAD in this setting. Thank you very much, Dr. Mahajan. Excellent demonstration of your case.
Thank you.